I'm Bonnie Mohan. I'm the Executive Director of the Health and Housing Consortium, and this town hall is organized together between the Bronx Health and Housing Consortium and the Brooklyn Health and Housing Consortium. I want to thank my colleagues at the Brooklyn Consortium, Amy Freeman and Harmony Arcilla, and from the Bronx Consortium, Tess Summer, who put this event together. Last year, we started doing some town halls around COVID to really elevate the top issues that we were hearing and get information and guidance out to those of you working on the front lines when it was really needed, and enable you to have an opportunity to ask questions of different government representatives and experts on various topics. So we're continuing that. We've heard a lot of feedback around coordination for people experiencing homelessness who are in hospitals and during COVID, particularly as the cases rise. And so we thought it would be helpful to bring folks that are involved in this issue together and hear from different perspectives, and allow an opportunity to have a discussion and any questions. So we thank you all for being here, and we really hope that, you know, we've selected some really wonderful speakers who represent hospitals, street outreach teams, and the Department of Homeless Services, all very critical to this issue. But you all are here because you work with this population as well, and so we definitely want to hear from you in the chat. Please feel free to enter your questions for the speakers in the chat, as well as any comments or experiences that you've had. You really want this to be as interactive as possible. So I want to just run through some housekeeping first as we get started. We're going to keep all of you on mute. We ask that you keep yourself on mute with your video turned off just during the presentations. And then once we're through with the presentations and we're into the Q&A, we welcome you to turn your video on so it can really be more of a discussion. Like I said, please use the chat box to enter your questions, as well as any comments that you want to share. If you would like to do so anonymously, you can send the chat privately to Tess, and we can read that question aloud on your behalf. We will also, in addition to the poll that is up on your screen now, we will have an evaluation poll that will pop up towards the end of this session, and we really would appreciate if you completed that and gave us feedback on this session, and that helps us in our programming. I will run through the agenda. So we are first going to hear from Cassandra White-Hemphill, she's the Interim Deputy Commissioner of the Department of Homeless Services for the Street Homeless Solutions team, and we're going to get some guidance and protocols around homeless individuals in hospitals and getting them connected to services within DHS. We have 3 different street outreach team providers here representing the Bronx, Brooklyn and Queens, and part of Manhattan, or rather all of Manhattan, the Manhattan Outreach Consortium. Then we have 3 hospitals here as well to share about what their policies have been around the patients that come in or individuals that come in who are experiencing homelessness, and you know, how they're connecting those folks to services, and especially how that has changed during COVID. And then we'll have a moderated Q&A and discussion, and that's where we'd love to hear from all of you as well. So here you can see our esteemed panelists. Like I said, we have Cassandra White-Hemphill from the Department of Homeless Services. Our street outreach providers are Casey Burke, Juan Rivera, and Erica Strang. And from the hospitals, we have Tatiana Celsis from New York City Health and Hospitals, Elmhurst. We have Dr. Nick Gavin from New York Presbyterian, and we have Dr. Jeffrey Lazar from St. Barnabas Health System. And we are going to be sharing in the chat the bios for all of these panelists, so you can look at those, but in order to save time for discussion, we will not read those aloud to you right now. So with that, I think that that's all of the logistics, and I will hand it off to Cassandra.
Good afternoon, everyone. I first want to say thank you all for having me here to talk a little bit about the work that is happening with DHS Street Homeless Solutions in coordination with health and hospitals. We do know that we're really in an unprecedented time right now, and so some of the work that we have done with health and hospitals has changed over the past year. But we're really proud of the continual coordination that we have in partnership with Health and Hospitals, along with DHS's Serious Incident Unit, our Vacancy Control Unit, our Office of the Medical Director, and also our hardworking outreach providers who are also on this call. I do want to share that prior to 2019, September 2019, DHS did not have a Joint Command Center, but we do have one now, and we're really proud of it. There's been some changes. It initially rolled out with NYPD. Now it is working solely as an entity in coordination with other city agencies, but we continue to try to prioritize rapid response around street homelessness, and when necessary, supporting the other divisions of DHS with homelessness. I do want to share that one of the pluses that we've had is that over the past year, in light of COVID, DHS has been able to open up an additional 1,000 stabilization beds, which are amazing, which allow us to place street homeless individuals and other individuals who are homeless throughout the 5 boroughs, which is something we did not have access to before. And after the last snowstorm, not the one that just passed, but the one before that, we have now also contracted to have a couple of warming buses to help support the emergency rooms at East Elmhurst, Lincoln Hospital, Bellevue, and Harlem Hospital. And we do have an extra bus that will rove and pick up folks who want to be transported to shelter or stabilization bed. I think one of the biggest things that we do now is that our midnight shift specifically, but all of our folks who work the Joint Command Center, specifically the management team, work really closely with the hospital EDs around folks who are in the hospital waiting areas. We know during COVID or pre-COVID, hospital waiting areas were a location that people would go who were street homeless for warming, and we know that we had to quickly pivot from that in light of COVID. And so what we have now is that we have redirected all of our partners not to direct anyone to hospital waiting areas, because of COVID. We know that that is not the place for folks to go, and anything we can do to redirect folks to our drop-in centers, stabilization beds, and other warming locations is what we're doing. But any event that there is someone in the hospital who needs to be discharged either after having been hospitalized or who just went in for care, we do have a Joint Command Center that is open 24 hours a day, 7 days a week, staffed by both a program administrator and a manager who can troubleshoot in real time, and they're often troubleshooting in real time with the administrator on duty at hospitals that contact us. And so what I want to share is information about the information that we would need in those events. I know that most of you guys who work in a hospital as hospital administrations or as hospital social workers already know this, but I think it's important that I reiterate some of the key information given our population, especially street homeless folks are really vulnerable, and sometimes it takes a little bit more engagement and work to get them to move the needle and to come into shelter. So we definitely need to know who's contacting us from the hospital. Is it the social worker, administrator on duty, or some other person? And we need client information. We're very aware of HIPAA laws, and we know that there's certain information that cannot be shared without consent, but any information that can be shared is helpful. And the reason for that is that oftentimes folks will present in a hospital waiting area, and they may present as homeless, but they may have a shelter placement and not be street homeless. And so if we can quickly identify the status of an individual, it will allow us to really be able to quickly place them. If they are street homeless, the goal is going to be to place them in a stabilization bed or a safe haven bed. And that's because those are low threshold placements that don't have the same requirements as shelter. If they are a shelter client, we are going to try to place them in their previous shelter placement, or we're going to try to place them at a comparable shelter placement. And sometimes you'll have folks in the hospital waiting areas or who have been discharged who absolutely do not want to go back to where they're coming from or their previous placement. And we want to have that information as well, because we don't want anyone discharged to the street. We want them to be placed either in a shelter or a stabilization bed. So once the Joint Command Center gets this information, we're immediately going to work directly with our DHS entities. We're going to work with the our respective outreach, contracted outreach provider, who oftentimes are the ones who go to the hospital to pick up individuals, and then we're going to prepare a placement so that that person can go straight from the hospital to a shelter placement. I do want to make sure, I see that we're still on the slide for the Joint Command Center. Let me make sure I give that number out. We do have the 212-607-6040. That number is answered and manned 24 hours a day, 7 days a week, as is our email address, which is shccc@dhs.nyc.gov. That goes directly to our entire management team, who will respond in real time and provide feedback and guidance with information right at that moment to help make the best decision for the individuals. Next slide, please. And so we definitely need to know, again, who the individual is that we're looking to place. We need to know for sure if the person has a previous shelter assignment, because that's going to help us, and then we're going to work very closely to provide a placement. One thing that is different is that if a person has been hospitalized, so they're not a person who came in for a treatment that day, but they have been hospitalized and now being discharged, if they are known to the street outreach teams, there's work that we try to have happen before the person is discharged, because the goal is to have a discharge plan for anyone who is known to the street outreach teams before they're discharged, and that is the same for shelter. I know that there's an institutional referral process that we work closely with the Office of the Medical Director on to ensure that we have a plan in place, because again, for our street homeless folks, a lot of them are tremendously vulnerable. You know, there are oftentimes other things going on. It could be substance abuse, it could be some mental health issues, and we want to make sure that we're being as proactive as possible. So whenever we can, we do want to try to put things in place with a discharge plan in coordination with the hospital social worker, the hospital team, our outreach team, the Office of the Medical Director, and a respective shelter staff. So just wanted to flag that. Next slide. Okay. So one of the things we were doing pre-COVID is that we were dispatching teams both from our Joint Command Center. We do have a handful of crisis coordinators and canvassers that are part of the Joint Command Center. But in light of COVID, we have not been able to retain the same level of staffing. So currently, the main folks who are gracious enough to make sure they respond as quickly as possible to the hospitals as a resource are our street outreach providers. And so those folks are on, but they're the ones who more than likely at this point will come to the hospital to retrieve folks from the hospital, or we may work with the hospital to arrange transport via, you know, some sort of a van, bus, or public transportation if necessary. I do want to flag that there was a question around Code Blue, and we had a lot of Code Blues this year, and it's really difficult to manage within Code Blue in the world of COVID, because we have a lot of really, really vulnerable clients that our outreach teams are prioritizing during COVID, and so during Code Blue and COVID. And so what happens is that there may be a bit of a delay or a lot of coordination that is happening on the back end, because the outreach teams are focused on the several hundreds of vulnerable folks who we know are in the community that need support and need to be monitored, because our goal is to really get them in off of the streets and during the Code Blue, which is the really cold weather. I do want to also add that there are a couple of things that we do have that are available to the hospitals as a resource. We have pamphlets that we distribute that have a lot of information around the programs. We've also been working with some of the hospital leadership or in talks about how we can make sure we develop lists, for example, around Lincoln Hospital, that include all of the other resources like the drop-in center that's near their soup kitchens and things like that. So we do have a list that we use as a resource for homeless individuals that we try to share with the hospitals. We have pamphlets that give direction on how street homeless folks versus regular shelter folks could access services. And we have street sheets, right, which lists actually the things that are directly operated by us, which include safe havens, drop-in centers, soup kitchens, which are not ours, but are in the vicinity. And we also access information around clothing donation locations. We know that's really important. But I think the most important resource that I think has been tremendously helpful to both street homeless folks, our outreach teams, and our partnership with Health and Hospital has been this project that we were able to kick off in September of 2019, which is the Joint Command Center, because that really allows street homeless solutions to do things they have historically not been able to do, which include really be a support and a resource to the hospitals in real time, answering questions, dispatching, coordinating, drawing on any DHS resources, including these newly available beds that we have over the course of the past year. And we think that that is the best way to get quick assistance, quick guidance, and accurate answers on how we can support whatever issues are happening within the respective hospital waiting areas or around discharge for DHS street homeless clients and sometimes shelter clients as well. So I will end it there, and I'll be available for questions that speak specifically to anything. I do see we have a COVID-19 slide, and I think this is just an informational slide. Since COVID became a thing in March, DHS has been extremely proactive around making sure that we kept a really tight system to manage COVID-19. As you guys know, we directly operate isolation sites, we directly have quarantine sites, and we also have now a vaccination site, a vaccination pod that's being operated by DHS. So we've been in the game hand in hand with the rest of the city agencies, and we've done a really good job of managing our system. But one of the things that our hardworking outreach teams do to help make sure that street homeless folks are being supported is that when they engage, these 3 questions are asked for every engagement that happens with the DHS outreach folks, our Joint Command Center folks, and our outreach teams to ensure that we are screening street homeless individuals for COVID-19, because we do not want them to be on the street in a very vulnerable state or be in a space where they may spread the disease. So we are working really closely with street homeless folks. And those are the 3 questions that we have been asking. They've changed a little bit since March, but for the most part, these are the questions that we use to screen all street homeless folks. And we have been doing this since March of 2020. So any other questions around that?
Great. Thank you so much, Cassandra. And now we are going to have the opportunity to hear directly from the street outreach teams. So I'm going to hand it off to Casey Burke from Breaking Ground, which does street outreach in Brooklyn, Queens, and part of Manhattan.
Hello, everybody. Again, I'm Casey Burke. I'm the program director for homeless outreach in Brooklyn, and I also oversee one of the new stabilization bed programs that is part of the DHS COVID response. We have an 80-bed program in Williamsburg. So as Cassandra said, we're always working very hard, and COVID has changed some things about the way we cover winter, but it's not changed that many things. We don't have the hospital EDs for clients to stay warm in anymore, and that's definitely been a hard hit for our programs. But we thankfully do have some more resources for places for people to go inside in the stabilization beds and other new DHS placement opportunities. So that has been really helpful. I think that the way we work with hospitals is pretty much the same year round. We try very hard to make sure that all the hospital EDs and the inpatient units and the social work departments have our information and understand as much as possible what Breaking Ground or the other homeless outreach programs do, and what sort of services we can provide, and the ways that we can accept referrals. We really want to be aware of any person in our borough, in our catchment area that is experiencing homelessness, and want to do what we can to get them off the street. And so do appreciate any connection we have with hospitals. I think that it's challenging because we can't always solve a problem right away. We do have clients that we know and that we're working with, and there are times when the hospital will call us and say, hey, there's so-and-so is here in the ED, or so-and-so is inpatient, and we can say, oh, thank goodness you found this person, we know them, and we've been trying to connect with them. And then other times it is a person that is has been maybe they've been homeless, but they haven't touched the social service system. They've been sleeping on people's couches, or they're very newly homeless, or they've been flying under the radar in the myriad ways that people fly under the radar. And so we will not be aware of them, but we can use that, that first touch they have with the hospital system to begin our relationship with them and begin learning who they are and what sort of services they need, with the hope that maybe a stabilization bed is available for them right then, or maybe they need other services like a safe haven or another sort of program where we can get them in down the road, but we have a relationship with them, and that we get to know them from that touch in the hospital and can start working with them moving forward. I think for hospital staff, the main thing is to just be patient and to understand that we might not be successful every time. It may take several tries. You might call me for 5 different clients, and I might be able to help you with one. But with that one person, we might have a shining success, and be able to get that person indoors and be able to start working with them in a more intensive way within the outreach program. And so, I know I have worked in hospitals in the past, and I understand it can be really frustrating to call 1,000 times and to get no's 1,000 times, but we really, really hope that people will continue to try reaching out to us or reaching out to DHS or however you make a start in connecting our clients to the outreach teams, because if it works well, and we're able to really help people and get them inside and get them started kind of on the road to having the benefits they are entitled to, and the care that they need, and the housing that is their right. And so we are I think for a lot of folks, the best inroad to that, and really want people to have that opportunity. And I think specific to winter, a big challenge for us is the helping to transport folks from the EDs at times. When it's very cold outside, our resources are stretched very thin, especially in days like we've had this month so far, with so much snow and such intense weather. We are not able to pull our teams from the street to come to an ED, and so we want to be able to work with the hospital providers to find a way to get the person that's inpatient or being discharged or in the ED and needing a place to go. We want to be able to work with them to find a way. That way probably is not us. And so just kind of understanding that and knowing that it might be us helping you find a way, but we are probably not going to be able to be the entity that transports a client during an intense weather day, or very low temperatures or snow or sleet or rain. We are really focused on having folks on the street and connecting to people and getting them indoors in that way. I think that's all I have to say. I don't know if I used all my time.
Thank you, Casey.
Yeah, thank you.
Yeah, well, I'm sure we'll have more questions later. Thank you so much. And the importance of setting expectations and really understanding what each of us can and can't do is so important. So thank you so much. And I'm going to hand it off to Juan Rivera, who's the director of the BronxWorks Street Outreach Team.
Yep. Thank you, Bonnie. Hello, everyone. So yeah, I guess I just want to kind of echo some of the stuff that Casey already mentioned. I'll take it back a little bit in terms of our history with hospitals and how we've sort of managed our relationships with hospitals. I think we've tried to always sort of incorporate ED outreach into our what our teams do on a shift by shift basis. And I'm talking pre-COVID, obviously. Like I think we made it a point, years ago, we understand there's a subpopulation of folks that, go into EDs. And so we have to outreach those folks. And so we always make that a part of our shift. We make sure the team goes there, they walk into the ED waiting area, they make sure they're canvassing there, or they might talk to staff at the hospital, maybe even go into the ED and see if there's anyone that we can outreach to. So that's always been sort of like a initial strategy that we use to kind of build up relationships with different hospitals. And then later, I think sort of out of necessity to manage some of the referrals that we were getting to the drop-in center, we came up with this hospital coordinator position, which is sort of a liaison between the team and the different hospitals in the Bronx. And that role kind of evolved into a bigger thing for us where, you know, we can manage referrals that were coming in. We could also advocate for clients that we were sending to the hospital. And we really tried to streamline a lot of the communication through that person. Um, Now, you know, it's one person, so obviously the communication, you know, is not always going to go through that person. And I think, you know, having worked in a hospital myself as well, I know that there are so many layers and so many different departments and so many different floors, and you know, the messages don't always get from one place to the next, and people don't always know who to call. So I think, you know, the teams end up fielding some of this stuff individually. Like I'll get calls, or you know, the team might get a call, or one of our coordinators might get a call. But you know, we really try to push the hospital coordinator as sort of the main contact person, so we can maintain some kind of consistent communication, and there's you know, less confusion about what's supposed to be done, and who, you know, who needs to talk to who. And lastly, I think, you know, as we've evolved in these relationships with hospitals, we also, you know, when the Mac series came along in District, you know, we developed these ED programs where we actually were able to embed staff that were part of our team into particular hospitals, into the EDs of particular hospitals, to really work, you know, on an ongoing basis with the clients that are there, that are being engaged, and the staff, and to, you know, help sort of, you know, case manage those folks and really connect them with our team, and get them into some of the beds that we have available, for the folks that are eligible for those beds. So now, you know, obviously, like the COVID world has been different. You know, once COVID became a thing, you know, we really sort of discouraged staff from going to EDs because we didn't want folks to be put in harm's way. And I think, you know, the hospitals actually preferred that we didn't have people sort of roaming around in the hospitals unnecessarily. So so that was sort of a mutual thing that worked out. It's been tougher in terms of, you know, transporting folks, you know, picking people up. I think there's been fear from the staff, obviously, about, you know, putting people in vehicles and making sure that, you know, if someone was in the hospital with particular symptoms, that, you know, maybe we find out if they'd been tested and all that kind of stuff. But it has made the work harder in terms of being able to physically visit the hospital. I think that you can do Zoom calls and you can do phone calls, but I think the face-to-face engagement with people is really what's important in some of these relationships, and I think that's made it a lot harder. And you know, Valerie, who's our hospital coordinator, is actually on this call today, so she's in there somewhere. She can comment on it later, I'm sure. But yeah, I mean, I think that, you know, like Casey mentioned, we do have these other resources now, right? Which is great. We can place people into other beds, and so we have more availability. I think it's, you know, making sure that, for us, I mean, you know, funneling people into the right settings. I mean, I think that some of the stuff that we have in terms of the beds are not always appropriate for everyone. So, you know, we want to make sure that if we're going to put a client into a stabilization bed, that's someone who is going to be able to, you know, do well in that setting. If it's someone who needs a safe haven bed, then, you know, we want to make sure that we try to get that person into that bed. And it's, you know, working with the hospital to make that game plan work, right? So, you know, maybe we don't have a bed today, but if you can hold that person one more day, you know, we can probably get them into this place. So I think a lot of it is sort of working on that and making sure that, you know, there's some kind of, you know, leeway there where we can work together to get the person to where they're going to benefit the most, so that hopefully you won't see them again in your ED. And I think, to talk about Code Blue for a second, yeah, I mean, it's tough to, you know, the teams we've always been focused during Code Blue on the people that are on the street. And I understand, I mean, you know, I can think of a couple of hospitals where we had a lot of folks that used to stay overnight during Code Blue, and the hospital would give them that courtesy to stay there so that they were safe. And that's something that in the COVID world, you know, is difficult. So, you know, there's been warming buses and other things that have been done to sort of help that. But definitely in terms of outreach, I mean, our goal is to always keep the folks that are on the street safe. And so, you know, for us to deviate to go to a hospital to pick somebody up or do something like that, it's difficult because it really does take away that time from the street folks who really do need it. And that's where our focus needs to be. You know, someone dies on the street, you know, we take that personally because that's our job, is to really take care of those folks. So there's lots of challenges, I think, with hospital work and outreach. I feel like it's an ongoing conversation. It's always going to be. There's going to be some successes. There's going to be some, you know, folks who slip through the cracks. But I think, you know, just sort of keep plugging away at it. And you know, I don't know what the solution is to sort of create the perfect harmony, but you know, I'm always a willing partner to try to get there. So that's all I got.
Thanks, Juan. We're working at it.
Yeah.
All right. Thanks. All right. I'm going to hand it off to Erica Strang from the Manhattan Outreach Consortium.
Hi, everyone. I'm Erica Strang, Director of the Manhattan Outreach Consortium at CUCS. I'm going to try not to repeat everything Casey and Juan said, but they make good points. So relationship with hospitals. They'll likely sometimes they'll reach out directly to DHS, as Cassandra mentioned, through the Joint Command Center, or also through the referral hotline to get a sense of whether somebody's connected to a street outreach program. And that would help hospitals get the information about which team to connect to. So I often receive, you know, voicemails from a social worker from a hospital in Manhattan asking me if we're familiar with somebody that they're working with, somebody who's admitted and is reporting the street homelessness. And then that way we can really connect and see if they are already known to a team. And if they are, then I'll connect them to that team and they'll work on discharge. And if not, then we'll see what sort of connection we can make. You know, I think that the relationships are also formed we have a system by which we subcontract with 2 other providers, Breaking Ground and Goddard Riverside. And we divide up Manhattan into 4 catchment areas. So I think that the teams that are working in those catchment areas make relationships with those hospitals. You know, if you're doing street outreach up in Harlem, you're going to make a relationship with Harlem Hospital, you know, that's in your catchment area. There are over 20, I just did a quick search the other day, there are like 20 or so hospitals in Manhattan that I was able to find. So there are a lot of different hospitals and a lot of different connections to be made. And we found that really, you know, over the years, it's about sort of the consistency and longevity of staff. You know, if you have a social worker that's working in a hospital for many years, they're going to get to know, and they're working in the CPAP, for example, they're going to get to know street homeless individuals that come in and out, and therefore make connections with the street homeless providers. And so when we're having staff that have worked in the hospital for a while and outreach for a while, those sort of connections are made. But the overall sort of systematic connections are where we're a little more, we need some work on that, figure that out a little bit better. So let's see. So as mentioned, you know, things have changed in regards to COVID. We don't utilize the ERs as a place for folks to go in and stay warm. People are going to still go into ERs during Code Blue. We ask our staff to, you know, to really not go into hospitals unless they absolutely need to. But we continue to engage in the same way with hospitals when they reach out to us about street homeless individuals, to work to be able to connect to that person and provide a good option for them. You know, as mentioned, you know, Code Blue is, you know, our focus is on the street, and DHS actually in Manhattan has been able to provide some assistance, as Cassandra mentioned, with transport during Code Blue from hospitals to shelters or stabilization beds if somebody is interested in going, and that's been really helpful so that we can keep our teams focused on the street, and perhaps, you know, if more we could have some more of that maybe in the outer boroughs and more in Manhattan, we could have some assistance with that transport. I think that would be a helpful thing as well, especially if someone wants to go to shelter, they should be able to go and get assistance, and also just, you know, collaborating with the hospitals about how to get the person there if it's not something that outreach can do in the moment due to Code Blue. So I wanted to mention specifically, Bellevue is one hospital that we have connected with in various ways over the years, and I think because we've had different initiatives with them. Also, I think because the street homeless population downtown is there's much more density downtown of street homeless. So folks that are, our teams that are working south of 59th Street. Are going to utilize Bellevue as a city hospital in the downtown area, and Bellevue is obviously a great partner as an H&H hospital. And right now we have, most recently, MOC has contracted with Bellevue to provide a housing navigator for their primary care safety net clinic. And so this is a licensed social worker that is a staff member of CUCS and MOC. Supervised by my colleague, and is working within the primary care safety net clinic to assist folks. And sorry, the primary care safety net clinic is an outpatient clinic for folks that are homeless that practices out of Bellevue, and the housing navigator works with the social worker and the care coordinator in that clinic to assist them in finding the appropriate housing services, obviously with her connection with MOC, and also with the other outreach providers. If we find that a patient of the clinic is not yet connected, is reporting street homeless history, but is not yet connected to a provider, then we will work to connect them with the street outreach team where they usually spend their time, which is often in Manhattan, and we'll connect them with the teams to work on figuring out housing. And our housing navigator will also work directly with the clients ourselves to figure out, what the best possible solution, if it's doing the housing packet, or connecting with the assisting the shelter worker where the client is staying with housing options. So that's one way in which we've made a connection directly with the hospital that I think has strengthened our communication. So I look forward to talking more with everybody and getting a discussion going as we talk more, and I'm interested to hear from the hospital folks. Thanks for having us.
Great, thanks so much, Erica. And I'm going to hand it right off to Tatiana from Health and Hospitals Elmhurst.
Hi, everyone. I'm Tatiana. I am a social worker in the emergency room at Elmhurst Hospital. I wanted to start by talking a little bit about what we would do with some of our homeless patients pre-COVID, which is that we had a trailer in the back of the hospital. During Code Blue, they were allowed to stay there overnight to keep warm and would be provided with blankets, water, and social work services as requested if they were interested in going to a shelter or some other service that they felt that they wanted a social worker to help them with. Typically what we do is patients are referred to us to social work if they are homeless and in need of assistance. We do an assessment for safety, make sure that there is no other issues going on like domestic violence or that they're feeling threatened in any way. And if they agree to shelter, then we will reach out to the shelter. I know they had mentioned the DHS line, make sure that they're not already known. Otherwise, they're given one of the intakes centers to go to, and we can provide them with a Metro card and directions on how to get there. Now, once COVID started, we did get one of the Dhs Warming Buses that comes at night at 10 o'clock and stays until the morning. And that is something that I know has been utilized by a lot of the homeless population around our hospital. They're aware of it. They come to the hospital at night. They wait in the waiting area, which we have socially distanced by blocking off certain seats so they can sit there until the bus arrives. And that has really been really helpful for patients that don't necessarily want to go to shelter but don't have any other place to stay. I did want to talk a little bit about some of the barriers of getting patients to go to homeless shelters. Some of the ones that I'm sure everyone knows is substance abuse and mental illness. Those things can definitely be barriers as to why someone does not want to go to a homeless shelter. Also, just having a bad experience is something that a lot of patients have spoken to me about, where they have gone to a shelter and they were either assaulted or robbed. And because of that one bad experience, they're very reluctant to try again and to try to get the help that they need, despite us telling them the services that are available at shelters and how we can help them get out of this situation. That is one of the most common things that I will hear from patients is, I tried that and I don't want to do it again. I had a bad experience. In particular to Elmhurst community, and I'm sure many other communities throughout New York City, a new type of homeless that we have gotten recently because of COVID is our undocumented population. So in Elmhurst, we have a very large undocumented population that will be in a living situation where they are renting out a room of a house or an apartment, and there's no formal lease, there's no formal contract. They just pay cash to someone who has allowed them to stay in the house. And because of COVID, many of these people have lost their jobs. They were frontline workers working in restaurants as delivery men or cleaners, and they were not able to pay their rent. And despite the moratorium on evictions from the governor, they were kicked out of their homes, either because they weren't able to pay their rent or sometimes because they had COVID and their landlord told them, I don't want you to stay here anymore. And because they are undocumented, there is such a fear of enforcing this eviction moratorium that they don't want to call the police because they can't guarantee that they are not going to end up deported if they try to take any legal action. They're afraid to go to shelters because they don't want to give their information. They don't want to do anything that would require them giving a name, anything that might end up in their deportation. So I'm sure you've seen on the news, or there's been a couple of articles in the newspaper about this new group of homelessness in the undocumented population, which is a big, big portion of the patients that we see at Elmhurst Hospital. And it's just another barrier to getting a living situation that is safe for them. But I've seen a lot of that recently with COVID. A lot of the programs that you guys have been discussing is wonderful. Brick and Grounds does work with our hospital. They've reached out to us regularly during COVID, calling and seeing if there's any patients that are known to them that they might be able to help out with. And as I mentioned before, the warming bus has been very useful as well. But I did want to bring up those topics of just other barriers to homelessness that have been coming up recently because of COVID and how it has really affected the community that we work with and our patients.
Great, thank you so much, Tatiana. And it's always helpful to hear a real case of what people are experiencing and how this is impacting them. And so I hope we can talk a little bit more about the issue of those who don't have documentation. And I see some resources have been shared in the chat for those that have similar issues. So I want to now, because we're short on time, just pass it right off to Dr. Nick Gavin from New York Presbyterian.
Thanks, and I'm going to try not to be repetitive so we can move through things. First, I just want to say thank you to Ms. White-Hemphill and Dr. LaRock and the whole team at DHS. They have a job that is impossible and do not have limitless resources, and this whole group recognizes that, and we're very appreciative of everything you do and the outreach teams, what you all do with the limited resources that you have. I was asked to speak about our protocol for treating homeless patients. We do identify homelessness if a patient self-identifies at the time of registration, and then the patient undergoes pretty normal care unless housing is identified as a barrier to discharge, in which case they would be referred to our in-house social workers. How has that changed during COVID? The one piece that we've changed in our evaluation of homeless patients is that we've made accessible rapid COVID testing, because we know that's a barrier to discharge, either for treat and release patients or for admissions. So we're now, the fastest COVID turnaround time that we have is 20 to 30 minutes in the emergency department, a point of care test. So we're trying to get those done, particularly for homeless patients who were discharging from the EDs. So we have that information available when we're coordinating with our partners at DHS. As was suggested, for people who are street homeless and not DHS clients, those folks are referred to the men's and women's intake shelters that are closest to our hospitals, and transport is provided for those patients. For patients who are DHS clients or it's unknown whether they're a DHS client, then we're referring to the command center structure and getting in contact with DHS. One thing I wanted, and I'm a physician, I was helped getting into the weeds of all this information by one of our team members, Alba Ceballos, who's one of our senior social workers. One thing that just stood out to me is why we're not doing a better job of systematically sharing information. Why is it that the hospitals can't see where a patient is assigned to a shelter? Which outreach groups are they in contact with? Who's a breaking ground client? Who works with BronxWorks? I think there's a lot of work that we can do around transparency in this arena. That's something I would love to work on as a representative of the hospitals. Some of our particular challenges that I wanted to just highlight and maybe have some dialogue around are COVID positive discharges. So there's been some real variability in being able to contact DHS, and this has been not just at night, this is during the day. Sometimes we can get through in a few minutes, sometimes we can be on the phone waiting for hours. I just wanted to see if there's anything being done around that. The subway closures have been a real challenge for us, and I'd love to know, I'm not sure who this falls to, it's DHS or the outreach teams. Some of our facilities that are particularly close to the end of the line, our Allen Hospital is close to the end of the one train, have faced a surge of patients at the time of subway closure, and was wondering if there's targeted efforts to avoid that. And then I think this was addressed by the command center structure. There had been the perception that that operation was not 24/7, but it sounds like we're hearing today that it is 24/7. So perhaps that's something that we can work with Allison in Greater New York to get the word out about that. I don't know if that's a change, a recent change. That's something we can do a better job of just communicating internally. But those are some of the challenges I wanted to highlight. And again, just wanted to thank all of our partners in tackling some of this really, really hard work.
Great, thank you so much, Dr. Gavin. And I'm just going to hand it right over to Dr. Lazar from St. Barnabas.
Good afternoon, everybody. I want to echo Dr. Gavin's thanks to everyone participating in this call. Prior to starting med school, I actually worked a few years in Boston for what was then known as the Committee to End Elder Homelessness. Now it's called the HERF. But homelessness and housing insecurity has long been an issue that's near and dear to my heart. And I know what a challenging and complex sort of issue it is. And I just want to thank all of you for your sort of phenomenal and crucial work on behalf of myself and our department. Next slide, please. So when I was preparing to just say a few words today, I did want to review some of the data just to bring myself up to speed with where numbers are in New York City. These are 4 charts from the Coalition for the Homeless, showing populations sleeping in New York City shelters. I overlaid the little yellow dots to just show the year 2000. And what we can see is just the sort of frightening increase in New Yorkers who are requiring shelter beds. We can contrast that if you hit return twice, please, or advance twice, please. To the economic situation in New York City, we see the rise in GDP. And the second chart on the bottom came from Bloomberg News, which discussed the economic miracle in New York City over the past 15 years. So we have an economic miracle, but a moral catastrophe. Next slide, please. So I'm going to speak in some generalities here. I do think that number one, there are exceptions, and number two, delightfully, things are evolving very quickly in the right direction. But having worked in inner city emergency departments for the past 17 years and the past 14 here in Manhattan and the Bronx, I will say that most emergency departments currently approach homelessness much the same way our society does. We, and when I say we, the providers and the patients who are homeless or housing insecure, minimally acknowledge it. I was asked, what do we do when a patient presents with a primary complaint of homelessness or housing insecurity? Well, they almost never do. They couch their presentations in complaints of foot pain or back pain, intoxication, suicidality, chest pain, and these may be real medical complaints, which are clearly associated with their life circumstances, foot disease associated with walking and being outside, not being able to perform foot hygiene, back pain because they don't have a comfortable, safe place to sleep, intoxication due to substance abuse. So this is how these patients are showing up in our emergency department, and I'll speak a little bit more about that in another slide or two. We have not established a pathway to clearly identify and manage patients presenting with a sole or primary complaint of homelessness. We are trying to evolve that. In the past year, we have started screening for homelessness or housing insecurity on arrival, and we're still working on evolving what we do with that information once we collect it. Next slide, please. In my experience, again, in New York City over the past decade and a half, discharging homeless patients has traditionally involved providing patients with a list of homeless shelters and a Metro card. Here at SBH, we've had a phenomenal relationship with BronxWorks, and shout out to anyone here, including Mr. Rivera from BronxWorks, that has allowed for the pickup of individuals from our ED. And also during COVID, we have utilized the DHS outreach team and processes. And I want to tip my hat and acknowledge DHS and all of their work through COVID. I think it's been spectacular, and they have risen to the challenge. So thank you and congratulations on your work thus far during the pandemic. Next slide, please. So I think I'm preaching to the choir, and this seems to be a pretty unanimous view that the utilization of ED waiting rooms during Code Blue is truly suboptimal. I appreciate, and we appreciate, that it's well-intentioned. And what I drill into my residents is that an ER is our society's safety net, and we will never say no to any way we can assist society. That being said, if you can hit advance, please. To paraphrase Gloria Steinem, a homeless individual needs an ED waiting room like a fish needs a bicycle. It doesn't appear that it's fair treatment to the homeless, and it's also unfair to those needing emergency medical care. Next slide. This is what you might see during a Code Blue, and believe it or not, this is a more orderly night in the waiting room. And this is how these individuals spent the night with the issues that you can imagine would result from having this degree of crowding of individuals in an emergency department waiting room. Next slide, please. Okay, so listen, there are obviously, from the emergency department perspective in this unsophisticated ER doc, there are a ton of challenges. First and foremost, obviously, is a lack of resources, which is 3 words for 1 word, which is money. Here at SBH, we have 1 social worker for an 80,000 visit ED in a safety net hospital. And that social worker, who is a phenomenal individual, is truly focused on long-term placement of patients with acute or subacute medical needs, and unfortunately does not have the time nor energy to assist our sort of acutely homeless population. Another challenge in the emergency department is what we sometimes refer to as mission creep in the ED. These are all humanistic and noble foci of attention, but it's recognized, the ED is an ideal opportunity sometimes to interact and intercept patients, whether it's around suicide screening, HIV testing, violence screening, foreign travel and infectious disease screening, fall risk screening, human trafficking, alcohol, tobacco, substance use, and lastly, housing. So we have this great environment. We need to figure out how to use it tactically and strategically to begin to address a number of social challenges and social determinants of health. In New York City, I'll share, and this I guess is no surprise to anyone, is the lack of medical respite beds, leading to sort of a cyclical process where patients with housing insecurity or homelessness are admitted for medical issues. They are treated, stabilized, discharged, and due to lack of proper medical follow-up and a home sleeping environment that can sustain health, end up being readmitted to the hospital, oftentimes worse than they were the first time. And from a physician perspective, how do we address higher order needs in an overtasked work environment where our fundamental goal is to save lives and provide stabilizing medical care? Next slide, please. Happily, I believe there are plenty of reasons for hope, including this town hall, but I believe we've acknowledged that we have a problem and we're working strategically to focus on solutions. And I think partnerships and alliances will play a huge role in making ground in tackling this problem. In our own ED, as I mentioned, we are beginning to screen for homelessness and housing insecurity and develop interventions around this. We are increasing the sophistication of our clinicians, including the next generation of emergency physicians, that a medical history includes a social history, includes a housing history, and consideration of where that patient is going to go when their ED visit is done. I hope we can, and we're working on increasing research, which often leads to funding. And I believe a key intervention will be highlighting the economic cost of ignoring this problem and the economic benefits of addressing it properly. And then lastly, something that has excited me is the emergent subspecialty of what we call social emergency medicine, which promises to evolve our specialty's approach to homelessness and housing insecurity, and furthering a more holistic approach to the emergency department patient. I'll finish there, and thank you, everybody.
Great. Thank you so much, Dr. Lazar, and to all of our speakers. We have so much to dig into and not nearly enough time, but I want to, as folks please continue to put your questions into the chat box, I want to talk a little bit about services and particularly transportation. It's come up a few times, and so I want to ask Cassandra, and I know there's others from DHS but about the warming buses. So first, are those warming buses only available at health and hospitals sites, or are they being made available for the private hospitals as well? And then a follow-up to that, what other transportation options are there for people who are not able to stay in the hospital during a code blue, but the outreach teams are not able to come get them because rightfully their priority needs to be getting people off of the street at that time. So what other, whether it's from the hospital side or from DHS, transportation options to bring someone to a shelter or services? So Cassandra, can you speak maybe first to the warming buses?
Yes, so the warming buses that we currently have, there are 4 stations at the 4 hospitals are named, East Elmhurst, Harlem Hospital, Lincoln Hospital, and I believe Bellevue, and there's one that we use as a roving bus to go between hospitals and pick folks up. These buses we actually just came up with about a month and a half ago in an effort to support the emergency rooms and keeping folks from going inside during cold blue, and then we just made additional requests for funding to keep these buses all the way through spring, and so far we've been approved. They are only available, the ones that are through Street Homeless Solutions are only available at the hospital locations, and we're using those 5 buses to support those locations. Now there are other buses available, but those buses are contracted through one of our outreach providers, and those are at the 27 stations that we have for the end of the line. So as the doctor referenced, there is an end of line initiative where MTA closes their stations from 1 a.m. to 5 a.m. DHS has over 150 volunteers along with our outreach providers and BRC and MTA folks who are in the stations, emptying out the stations and offering services to individuals, homeless individuals in the stations. And they do have buses that are there that we can sometimes redirect to support our efforts in other areas. What we do have, I do want to flag quickly, we were told that our serious incident unit, which is a unit that the doctor referenced, does have buses that can help with transport. So if you give us a little bit of lead time, the Joint Command Center can reach out to the serious incident unit and ask them to help with transport. Unfortunately, Street Homeless Solutions does not have its own transportation available.
Okay. And how about on the hospital side? And Dr. Gavin, if you want to follow up on either if you provide any, or your hospital is able to provide transportation for folks to get to a shelter or other services. And then also following up on the subway line issue, are you finding that your patients are aware or are connecting? If there's a DHS street team that's coming at the end of the line, but you're still seeing this uptick in people in your sites, seems like there's a disconnect there, or are people just not interested?
Well, I guess I would ask, is the presence at the end of every line, or is there variability day to day? I'd want to hear a little bit more about what that program is like.
So yes, we are at 27 stations. I believe we're at most end of the lines, but there's a total of 27 stations that we are at 7 days a week from 1 a.m. to 5 a.m. This is the first that I am hearing about the hospital. I get an influx of folks, but I do have to say that everyone has to exit the train and they're not allowed to loiter in the station. So folks will move upstairs if they refuse services and do not want to go to shelter. What we have done is that when areas have flagged for us, like we've had a situation with Amtrak where folks will say, you guys are MTA is emptying out the station, folks are now going here. What we can do is work with the DHS folks, the outreach folks, our folks in the BRC team to figure out if we can then send resources to locations that we think folks may be congregating because they don't want to go to shelter. But we have to know about that ahead of time and we have to plan for it because the majority of the folks who are doing this work are volunteers. They are folks from DHS, DSS, and HRA along with our street outreach teams. Like you have Juan, Casey, Erica, those folks, their teams are above ground, but they've been helping with end of the line underground, along with our end of the line, which is BRC, who will handle the subway outreach.
And is there any timeline for when the subways will be open 24/7 again?
We have no idea. We've been asking that for months, yeah.
Do you think, I don't know, Ms. White-Hemphill, I don't know if you'd be willing to share this, but do you think you could share with this group the list of stations that are serviced and the services that are provided there?
Yes, we do have the list. Mm-hmm.
That'd be great, because maybe we could provide some feedback on that. That's really helpful. And to the question about what the hospitals are providing, we do things on a case-by-case basis. If a patient is, let's say they're at a BRC shelter in Chelsea, we would provide, and they can take the subway and it's during the day, then we would provide a Metro card if they don't have that. If they're going from Upper Manhattan to Brooklyn, typically we would do a car service, or we use Lyft occasionally. So we arrange transportation, but it's sort of on a case-by-case basis depending on the medical needs of the patient.
Bonnie,
Yep.
can I say something? Yeah, this is Scott Allwater from BronxWorks. And I do know one of the things that happened during one of the last snowstorms is we got several calls from one of the hospital expecting us to come and pick up patients at the hospital. And that's just not going to be possible. I think it's important for the hospitals to understand that the outreach programs are responsible for the welfare of everybody who stays out on the street. And when it's really cold out, when there's, especially in the case of a blizzard, you know, nobody's ever frozen to death in a hospital. And for outreach teams, I mean, that's our responsibility, is to make sure that nobody freezes to death who stays out on the street. Just another thing, home-based programs have received a significant amount of money that was privately raised, actually from a group of developers in New York. I've noticed that it's I think over $7 million. This money is specifically targeted to undocumented people who are, who are now unstably housed because they can't pay their rent because they lost resources due to the COVID epidemic. If you have a client that's in that situation, really important to call 311. I know that there's certain immigrants that worry that they'll be considered a public charge if they accept public benefits. These are actually not public benefits. These are privately raised benefits. BronxWorks, we got over $1 million. Queens actually got the largest allocation. So please, people should know to call 311 if they run into people that are in that situation, and get them to the local home-based program, because we can't help.
Great, thank you so much, Scott, for flagging that resource for folks. One last question on the warming buses, and then I want to move on to another topic. But are there, Cassandra, are there guidelines on what items a person can bring with them onto the warming buses?
No, there are not. What we do have is one volunteer who stays on the warming bus and works with the bus driver. We do try to create a social distance, stay within social distance guidelines, and we provide PPE, but there are no guidelines around what a person can bring on the bus or anything like that. We just want folks to come in and not be on the street, or whenever we can, to avoid them going into the emergency room.
And do you have any information in one place where people can find out about both the warming buses and the end of line buses, in terms of can they be contacted? If an ED is ready to discharge somebody near an end of line, and they want to get connected to services, go to a shelter, can they contact that station directly?
They can call the Joint Command Center. We have a whole transportation team that's working with SIU. They will call the dispatchers for the buses and try to locate the buses closest to location, whether it's at the end of the line or at a hospital. So they can definitely call the Joint Command Center, who has a direct line to dispatch and to the bus operators.
Okay, great. Thank you so much for that. Hopefully an easy question, but around vaccines, how can patients in the DHS system get vaccines, and what about for the street homeless population?
So we have not gotten approval for street homeless folks. I think they're working through the logistics. It's going to happen, but they have not figured out how to do it in light of the fact that you do have to have 2 dosages. So I know that that's something that Dr. LaRoque is working on, but currently DHS is prioritizing all of our clients who are in stabilization beds, who are in safe havens, and who are in shelter. We know some of our providers have other resources that they're using, but we're happy to say that we've passed at least 1,000 folks who've been already vaccinated, and we do have a pod that is currently run at our Jack Ryan Center in Manhattan. So we are vaccinating both our staff and our clients at this time.
Okay, great. This is a question for the outreach teams. One, can you just explain what a stabilization bed is? And do you find that people who are experiencing street homelessness are more willing to go into those settings than a traditional shelter? Any of you feel free to jump in.
I can jump in. Stabilization bed provides a place for someone to come inside. Can be a single room, sometimes shared with maybe 1 or 2 other people, but the majority of them, but they're not sort of dorm style, which can be the case for safe haven or shelter. So it's really having that own space for yourself. And there are, depending on the stabilization bed site, some of them have services and case management on site, and some of them do not. So it depends on the location, whether or not that they're going to have those services provided on site, but the person will always be connected to an outreach team, and that outreach team will be continuing to work with that person once they're in the stabilization bed. It has been attractive to folks coming in, especially end of line, or just in general, folks wanting to come inside. And I think a big piece of that is the majority of singles that are available, and also sort of just the low threshold nature of it. I think that sometimes folks coming into a program, while they may need intensive support, it can be intimidating for folks. And I think coming into a place where it's just like, hey, come in, let's get you a bed and a meal and a place to be warm can be more attractive to some people.
Great, thanks, Erica. A bit of a follow-up to that around drop-in centers, and I know we have some drop-in folks. Cassie, I'm not going to put you on the spot unless you want to jump in, but what are we seeing in the drop-in centers in terms of decreased capacity because of COVID? And is that really an option for the outreach teams to bring people in, or are they pretty much all at capacity?
Hey everybody, Cassie Dessalines. I am the program director at the BronxWorks Living Room Drop-In Center, and as well as the Safe Haven, actually. And yeah, it's definitely a challenge, right? Because drop-in centers are notoriously crowded. They kind of look like your typical high school lunchroom, and so we've had to really cut down on the amount of people that we can have. So we're at about half capacity right now. That being said, we are trying our best to manage, particularly during Code Blue. But we like for example, BronxWorks, as long as I've worked here, has never really had a limit on as many people as we could take. We've always really prided ourselves on not having a cutoff. And this is the first time in my history here that we've definitely had to implement some cutoff limits to the amount of people we can take. A drop-in center is kind of a tinderbox for COVID. It's a room full of a lot of people, many of them mentally ill, drug addicted, actively high. So they are not great at following directives. They're not great at following rules. So it's been a real struggle to get them to comply with basic protective measures, such as wearing masks. Washing their hands is like a definite probably not. Chronically street homeless people are not famous for their good ADLs, so there's that. So we've had to really, work hard on controlling the things that we can, such as census, and making sure that we're doing as much as we can with our maintenance. We have a really great maintenance team who's doing an excellent job doing disinfection every hour, and that sort of thing. It's also really difficult, I think, with hospitals. We have had to become really creative when we have a person who's either been exposed or has tested positive or is showing symptoms for COVID, because our buildings are notoriously crowded, as I said, so we aren't built with really great isolation options. So, we've had to kind of, put some things in place so that we could use a private office, but there isn't its own bathroom. So, I know that that's a challenge too, because when someone tests positive, but they're healthy, your kind of the hospital's initial thing is to send them home to isolate, but that isn't really possible in a drop-in center. And we have been trying to utilize the isolation sites that DHS has set up, but as somebody had mentioned, there is sometimes an extensive wait. We've waited up to 40 hours to get someone transportation to a isolation bed. So that's also been a challenge on the drop-in side of things.
Thanks, Cassie. That's it's so important. I think a lot of hospital folks don't necessarily understand the type of settings that some of these programs are and what they look like and what services are available. So I think it's really important to know what a drop-in center is like, especially now, and before making a discharge to something like that.
Yeah, Dr. Lazar pretty much showed a picture of it when he showed the waiting room. That's essentially what it looks like. It's just not in a hospital, but that's essentially the gist of what it looks like here as well.
So a follow-up for Cassandra, is there anything that DHS is doing because of the diminished capacity of drop-in centers to scale up other resources? And then I want to speak a little bit on the isolation hotels, but maybe we can start there.
Yes, absolutely. So I think in light of the diminished capacity for drop-in centers, which became really apparent to us in spring of 2020, we then pivoted to the stabilization beds. We know it's not the same because, of course, a drop-in center, you're not sleeping there. You're just going for a couple of hours to get a meal and to regroup, whereas a stabilization bed is a place that we look for you to stay the night, but that was our alternative because, again, stabilization beds are oftentimes single rooms or double rooms with social distance capability, and they just have a lot more services and support, right? We think that that makes more sense, and that was a good use of the resources that we had through FEMA. So we did pivot towards stabilization beds where we have now over 1,000 that have been utilized in spring. We did help some of our drop-in centers to de-densify, and some of them were able to pivot and redirect clients to other locations so that they could be able to manage the capacity that they had.
Thank you. And those stabilization beds are accessed through the outreach teams, is that right?
They can access it through the outreach teams, or again, we have folks coming in, by referral from also EDs and other places into the line. Once you call the Joint Command Center, they're going to go through the inventory and find the most appropriate placement for you.
Okay, all right, so that they can be accessed by calling the Joint Command Center from a hospital. Okay, that's good to know. So about the isolation hotels, we had another comment that we received about long wait times of around 2 days for those. So what is the expected timeline for someone to hear back when they've made a referral to an isolation hotel, and what should they do if it has surpassed a certain amount of time?
Okay, I'll start on that. I think, so I'll start about following the process. And if the process is followed in the sequence that it's set up, then things go very smoothly. So the first step is to call the DHS hotline to verify that it's a current DHS client. Now, we've heard sometimes there are delays and sometimes not. What we've been told is if there is delays, depending on what the call volume is on any given time, you should leave a message. Don't just keep hanging up and trying again because it just further delays that. So that's the first step of verifying. What we have also is sometimes the hospital calls and then they'll send my team the referral, but they're not put down on the tracker. So then there's a tracker that comes to us and says, these people have been referred from the hospital, they're verified to be DHS clients, so if and when you get a referral, you can review them. The issue with that is there also has to be very clear communication for the purpose they're calling and that they're requesting an isolation bed, because sometimes what happens is with the go back and forth, yes, they did in fact call, but they didn't ask specifically for an isolation bed. So this is a hotline that captures a lot of different activities. So not only does it capture isolation referrals, but our regular hospital referral line, various activities, right? So that's important to communicate with your staff. Make it very clear that you're calling not only to find out if this is a DHS client, but to request the isolation bed. Then when you send the referral, it needs to be fully completed. Every part has to be completed, because if not, my team reviews it within an hour, usually 7 days a week, 9 to 5, and they'll send a response. Very often, there's no response from the hospital for 4 or 5 hours, then they come back, then we have an additional question, we come back, the day ends. So sending a completed form in the first place and being responsive to back and forth emails will quicken the process. And then finally, you want to send the referral when the client is ready for discharge, or, about ready, right? Because it does take a few hours. Because we've had situations where client is cleared and then they're in the hospital for another 3 days, they deteriorate, and they say, oh, the person's ready to go now. We send communication through Alice and Burke that if someone is approved from the time, process might have started, say, February 1st, and they got approved February 3rd, for whatever reason, there was a back and forth. from February 3rd, at that time that the approval went in, you have 48 hours to discharge a person. If the patient is not discharged for whatever reason, when you're going to call the hotline again, and it's more than 48 hours from the time of approval, not from the start of the process, they're going to say you need to send an updated referral, right? So you want any additional updated information, what happened, why there wasn't, why the person wasn't discharged. And it can be simple, you know, in one case, there was a snowstorm and there was an issue with methadone, so that they delayed the discharge so that by the time the client was discharged to isolation, the next day they would have gotten a methadone delivery. So we're not looking for you to reinvent the wheel, but just be responsive to the questions that we ask, so we make sure that the person was stable since the time we initially approved. There wasn't any major changes in the status that we have to know about, and that, you know, we'll reapprove.
Can I ask a question on that? So is there any possibility of creating an online platform for all of this back and forth? Because it's interesting, 2021 phone calls and emails with scanned documents. I just was wondering if there's any movement to modernize that.
So this was set up overnight in response to a pandemic with no additional resources. The city is in a very bad state. So this is the best we have.
Yeah, if I can add, Becky, hi, this is Fabiana, Medical Director for DHS. We are under furlough, we can't hire, we have zero money. So that's, and in fact that we actually have a PDF form that can be emailed and not fax is actually, it's a system that actually I'm pretty proud of. We were able to do this literally overnight. But unfortunately, unless you are offering funding, we can't really do.
Well, that's helpful for us to understand that that's something where we would want to advocate.
Can I say something, Bonnie, on this? I mean, one of the things that we've worked really hard to do is to get our street homeless clients to sign real consents. And so now for the ones that have signed consents, if they show up at a hospital emergency room, we get an alert. I think John Betts is on the in this meeting as well. He no longer works for BronxWorks. He works for Breaking Ground, but he was really instrumental in setting this up. So there is, you know, there's a lot has happened on this, and you know, the reels work really well. We haven't actually been able to use the information as well as we can, and I'm not, you know, COVID has set things back somewhat. But again, for people who have signed consent that are an outreach client, they go to an emergency room, we know about it. And, you know, there's lots of opportunity to really expand on that. And happy to talk about that more if anybody's interested offline.
So yeah, I mean, that goes back to the question Dr. Gavin mentioned in terms of data exchange. It's a good idea. It's something that everybody wants, but it's much easier said than done.
But we've done it. It's in place.
Can you please? Yeah. So we at DHS tried, and we went to the point of, you know, getting something ready to be in place with Healthix, which then would communicate with all their other RIOs, and we hit some roadblocks. We revived this in 2019, and then everything went into a screeching halt in 2020 for the reasons that are obvious. But this is something that we are very interested in doing, and we'll happily start again when we come up for air.
So I just wanted to thank you, Dr. LaRock. The evaluation poll has opened, so we really appreciate if folks can complete that. I'm going to squeeze every last minute out of this conversation, so I'm going to keep plowing ahead, but please do that evaluation. So Dr. LaRock, just as a quick follow-up on that data piece, so you had already launched some kind of data sharing with the health and hospitals, right, and some kind of connectivity, is that right? It's just it hasn't made it out through, is it through like Worker Connect or something? I feel like
so yes, Worker Connect. Thank you for bringing Worker Connect. So I'm glad it's been so long since we used it. I almost forgot about it. So Worker Connect is a city platform that several city agencies can use. And so Health and Hospital is on it, we are on it. So what we try to do and what you're referring to is that we were trying to work with the Mayor's Office of Operation, I think, or Community Development, to get private hospital to be able to use Worker Connect, which would entail an MOU between the city and each hospitals. And I saw that at really a simpler way that the database already exists. And while it would require an MOU for every entity, a simpler way than try to get into a RIO, because it's really not easy to get into a RIO. And the consent itself is also a barrier, because we are required to get the client consent before we can even send the data. So the Worker Connect, again, conversation sort of died last year, but I think that's a conversation that we really should restart. That's a process that, sorry, I'm trying to get my dog.
Always love hearing dogs.
In the conversation. But yeah, we should, I mean, it would be great to try to work on Worker Connect.
Okay.
Hi, Bonnie.
Oh no.
Bonnie, I'm sorry, competing requests. It's Allison.
You got it.
I have actually, who's that? Andy Benjamin from one of my hospitals.
Yes.
It's Allison from Greater New York, and I just want to take a moment, and I know everybody's got competing meetings, Zooms, webinars. I really want to thank you for pulling this together. I think we, as a hospital representative for all of the hospitals, and we have a lot of champions on this call, have always had our silos to deal with. Poor Fabian gave me her cell phone number several years ago, and we have, over the course of pre-COVID, really been moving the needle on serving individuals with homeless and at-risk homelessness, individuals or families for that matter. And it's been a work in progress, but COVID has clearly put it in fast track for a lot of reasons. One is, scarcity of resources. Two is protecting vulnerable people who are homeless or at risk. And, Disrupt was a funny thing, and we learned a lot from it. But I think, we have this like colliding universe of best practices, crisis, emergency response.
Allison, I'm sorry. I'm going to have to argue. We've got 1 minute left. So, and I appreciate everything that you're saying. And I think we've got a lot to follow up on. Andy, did you have one last word?
I just want to say thank you to Fabian. Fabian, you've been great. Our communications at 9, 10 o'clock, 11 o'clock at night has been fabulous to move these patients from the ED and inpatient. The same thing with H&H. I receive the emails and I communicate with my staff and the doctors to move patients along. So from my end, I have no complaint about neither of them. Department of Homeless Services have been great, and so has been H&H.
Great.
Thank you.
All right, glad to hear that. Well, I just wanted to say, we're right at 5 o'clock, and I think there's obviously a lot more that we could talk about and need to. I hope that folks walk away with an understanding that this is obviously very complicated, a better understanding of what services are out there, what we're all dealing with, and that we can all, try to be a little flexible. I hope hospitals walk away understanding that you may not always be able to get that patient connected to services right away. And so figuring out, how you can adapt during COVID to make safe places within the hospitals for people who are experiencing homelessness to be until we can get them connected to services. I hope that we can keep increasing the services that are available. I just want to say thank you to all of you working on the front lines with this vulnerable population, and hope that you stay safe. And we'll be sending out the slides, and there may be a recording available. We have to run it by people, but thank you so much for participating, to all our panelists and those of you for joining, and I'll say goodbye. All right. Thank you.